you so much. So my name is Keith Coker. I am faculty at the University of Michigan. I am an emergency physician. I'm also one of the medical directors of a project called MEDIC, the Michigan Emergency Department Improvement Collaborative. And we've partnered with the state of Michigan, the Michigan Department of Health and Human Services, to advocate and support implementation of HIV screening programs in emergency departments around our state. And as part of that work, we are hosting what we're calling a learning series. Many of you may have been at these already. And today we're going to be talking about the epidemiology of HIV, hepatitis C, and syphilis. And we've got experts from the state of Michigan to talk through that with us. I just want to remind you to complete this survey again. There's a QR code there. There's also a link in the chat. And it's a brief survey just to help us monitor the progress with the learning series. I'll also be monitoring the chat. So if you have questions, please put them in the chat. We'll have time and space to ask questions of our experts. Yeah, it'll definitely make this a much richer conversation. All right, so I'll leave it at that and ask Jen Miller, who is one of the state's epidemiologists, to step in for the first conversation. Thanks, Jen.
Thanks. Can you see that? Everybody can see that, the screen? Just making sure.
Yeah, looks good, Jen.
All right, great, thanks. Hi all, I am Jen Miller. I am one of the HIV epidemiologists in the Bureau of HIV and STI programs. And I am joined today by our HCV colleagues, Jeff and Vishal, who will take over. We'll do the second half of the portion, so I'll let them introduce themselves during their portion. For my half, I'm going to really be talking about just a real brief overview of some 101 stats for HIV in the state, and then talking a little bit about the different HIV care stages and their relationships to emergency departments. And then the meat of the HIV portion is EDs as transmission disruptors. There really seems to be the potential to interrupt up to 1 in 3 HIV transmissions with opt-out screening. And then a little bit about opt-out screening rationales by county, some syphilis trends, and then I will hand it over to HCV. So just real quick, whenever I say opt-out screening, I am referring to that recommendation that everyone 13 to 64 be screened at least once for HIV, and then more frequent screenings for those with known HIV risk. All right, so 101, if you're at the kickoff meeting, you saw this stat. The CDC estimates that 1 in 7 individuals with HIV are unaware of their status or undiagnosed. On the diagnosed side of things, prevalence continues to rise because the number of new diagnoses is higher than the number of deaths. Diagnoses and deaths have been decreasing significantly over the past several decades, but because there are more new diagnoses and more people moving into Michigan with HIV than there are deaths and people moving out, our prevalence does continue to rise. Detroit carries the highest burden of HIV for new diagnoses on the left in orange and prevalence on the right in blue. But there are individuals with HIV in every single county in the state. And just as a quick color reference note, new diagnoses will always be shown in orange and prevalence will always be shown in blue. Black and African American men experience the highest burden of HIV by far. Diagnoses are significantly declining among Black men and women, but there is still a huge disparity. This symmetry that you see here between new diagnoses and prevalence is the norm. Prevalence rates and new diagnoses rates are highly correlated. Just because individuals in communities with high prevalence rates are more likely to contract HIV solely because there is more of it in the community. They are more likely to encounter it. One of the main exceptions to this symmetry or this correlation is when we look at age. Highest diagnoses are among those 20 to 34 and kind of 39, whereas the highest prevalence are among those 30 and up. And a major measurable factor is the difference in community viral suppression. So when an individual maintains and monitors a suppressed viral load, they cannot transmit HIV sexually. You may have heard this referred to as U equals U or undetectable equals untransmittable. So when a large portion of the community is virally suppressed, the transmission rate of the entire community drops and therefore diagnosis drops. So for HIV, the older the age group, the higher the community viral suppression, and the lower the transmissions. Another side note, just based on HIV genotype data that we do have, networks in Michigan do tend to stay in groups within 10 to 15 years of one another. So the high diagnosis rate among the young people isn't from being in networks with older folks. And then the last portion in this section is unknown transmission route or risk. So it jumped significantly in April of 2020. So what's shown here is the unknown transmission route at initial case report. So we at the health department lower this to about 30% eventually. But this is the proportion of newly diagnosed individuals with unknown risk based on what the provider sent on a case report form or what surveillance was able to find in an EMR or some other medical resource. So risk-based testing obviously requires the tester to know the risk of an individual, but risk is unknown for at least 60% of newly diagnosed individuals, even after diagnosis. And universal opt-out screening removes this element that causes diagnoses to be missed. All right, so care and EDs. These are the 4 measures we have at the surveillance level for all persons with HIV and the ones we use the most often. New diagnoses, which are becoming much more common in emergency departments, and then their subsequent linkage to care. And then on the prevalence side of things, we look at the full calendar year and assess the proportion who are in care and virally suppressed. So most individuals diagnosed in an ED are successfully linked to care. 76% of diagnoses in an ED were virally suppressed within 6 months of that diagnosis. And this is the strongest indicator we have for successful linkage to care. This rate is much, much higher than it is for urgent cares and blood and plasma centers, which are the other 2 facility types on this chart that really see the broad swath of the general population that an ED would see. And if you missed it, previous presentations have covered partnering with the health department to take care of the linkage portion after a positive test. So if you missed those, I highly recommend watching the recording or at least checking out the You Test, We Do the Rest one-pager. And those resources are available on the Medic HIV screening page. And then this is 6-month viral suppression over time. It went up and then it plateaued. Moving on to care and viral suppression, the care rate, which is this dotted line up here, it stagnated in 2016. It dropped in 2020, and it has yet to return to pre-2020 levels. The care rate effectively acts as a ceiling for viral suppression. This is that community viral suppression that we were talking about earlier. If we just look at people who got a viral load, viral suppression goes up every year. It went up in 2020. It went up last year. It goes up every single year. That's not pictured here. But that progress is primarily attributed to better treatment options. But overall, viral suppression cannot increase unless the care rate increases. So opt-out screening is also an opportunity to identify and relink individuals who have fallen out of care, hopefully improving care, allowing community viral suppression to rise, reducing transmissions, which is what we are looking for. And that brings us to the central theme of the HIV portion, which is EDs as transmission disruptors. So a few years back, CDC published estimated incidence per 100 individuals with HIV between each stage of care that we just talked about, diagnosis, care, and viral suppression. So these are called HIV transmission rates, or HTR. And if we apply them to Michigan, we get the following. So this first group includes undiagnosed persons with HIV who are in the highly infectious acute stage. So for every 100 individuals that fit this criteria, CDC estimates there are 16.1 new transmissions. So the new transmissions is what's represented by the little people per 100 individuals in that group. This transmission rate is extremely high, more than 4 times the overall state average. But because the acute window is relatively short, there are very few individuals in this stage at any given time. So this group accounts for an estimated 4% of all the transmissions. The next group is undiagnosed non-acute. So the HTR is lower, but it's still high. And this group makes up a larger portion of all persons with HIV. And so together, all undiagnosed persons account for 42% of all transmissions. Moving on to diagnosed individuals who are not in medical care, you can see the transmission rate lowered. So before even talking about them specifically, if everyone who was undiagnosed was diagnosed and not in care, so if everyone in these groups had this transmission rate instead of these transmission rates, the total number of transmissions would drop by 11%. Just by diagnosing people. We're not even talking about linking people to care yet. Just by diagnosing people, the number of transmissions would decrease by 11% based on these estimates. So going back to this group, diagnosed not in care, they account for an additional 40% of all new transmissions. So these are the individuals that opt-out testing would find, undiagnosed and diagnosed not in care. The remaining 18% of transmissions are attributed to those in care but not virally suppressed. And then again, those who are virally suppressed cannot transmit HIV sexually, so it's 0 transmission rate. So just as an overview, again, if everybody undiagnosed were diagnosed and not in care, transmissions would drop 11%. There's no real reason to believe that people wouldn't get into care. So if we distributed those undiagnosed into the care stages at the proportions that people currently are, transmissions would actually drop 34%. So EDs have the potential to play a large systematic role here. And again, opt-out screening program would identify undiagnosed and those not in care, and these numbers don't even account for those who are not in care if they were relinked to care. Another question that gets brought up a lot is where opt-out screening makes sense. So in Michigan, there is really a rationale for almost every county by looking just at HIV surveillance data. The nuance is which justifications apply really varies by the county or the region. So for this section, a few important things to remember. County population does not equal patient population. Patient populations obviously are not defined by county borders. And then again, this section contains a portion of surveillance level data. There's more surveillance data, and I don't even begin to go into the realm outside of surveillance data. So we'll start with an easy one. This is a map of those individuals who are diagnosed but not in care. Again, accounting for an estimated 40% of transmissions. So think of this as like it's very rough. This wouldn't pass like any sort of peer review because there's lots of other factors going on. But think of it as a rough probability that someone diagnosed with HIV and not in care might walk into your ED. So obviously Detroit has the highest number, the highest rate of not in care per 100,000 residents. That's not really surprising. But I think some other counties may be a little surprising. So Oakland and Genesee County, 2 of our highest morbidity counties after Detroit, both have lower not in care rates than Mackinac, Oscoda, Lake, Berrien, Calhoun. And I didn't put numbers on every single county on this map because that would be overwhelming and you wouldn't be able to see anything. I think what most of us want to know, though, is where are the high levels of undiagnosed? And this is much trickier to answer. So we can start with the simplest and strongest measure, the CDC's HIV screening recommendation that healthcare providers should initiate voluntary HIV screening for all patients until there's less than one diagnosis per 1,000 screened. So that's that 0.1% positivity rate that keeps coming up. We began getting negatives, all negative screens in the state in 2019. And as of 2022, we estimate we have over 90% of all screens. And for the first time, we can assess population level testing and positivity rates. So 34 of the 83 Michigan counties, plus the Detroit local health department jurisdiction is broken out here, meet that threshold of at least one new diagnosis per 1,000 screens. And there's two or three really relevant limitations to this for all of you. It's unlikely this reflects the positivity rate in your hospital, right? EDs are much more likely to serve more vulnerable populations than the general populations. So just grabbing a couple examples from previous presentations in this MEDIC learning series and then from some other work. Based on Dr. Mantovel's presentation, the rate of new positives at Henry Ford in Detroit was 25% higher than the population level positivity rate used here. Similarly, Dr. Swartz's presentation showed a positivity rate 30% higher at Hurley Flint compared to the Genesee County's population level positivity rate that's here. A hospital in a jurisdiction that didn't meet the cutoff, they had less than one, the jurisdiction as a whole had less than one new diagnosis per 1,000 screen. When that hospital expanded testing, they found 5 new positives for every 1,000 screen. And that's like at a population surveillance level, that's like a massive positivity rate. And then the other limitation is, well, we have more than 90% of the screens statewide. It may not be exactly equal across the whole state. So both of those limitations are really good reasons to at least do a trial run of opt-out screening to determine positivity rates among your patient populations specifically. And then, of course, in order to get a positive test, enough people need to be screened. If no one is screened, no one can be positive. There are additional indicators of undiagnosed HIV. These are the measures I'm currently looking at to supplement that positivity rate. Unscreened rate per 1,000 residents, the new positive rate to screening rate ratio, that helps balance out any discrepancies in screening rates. Like you could have a relatively average positivity rate, but if the screening rate is very low, the ratio of those things combined may indicate an issue. HIV transmission rate, which we talked a lot about, this looks for that imbalance in the symmetry between prevalence and new diagnoses. If there's way more diagnoses than what we would expect. Late stage diagnoses, the proportion who advance to stage 3 within 90 days indicates individuals have been living with undiagnosed HIV for years. And this group is the most likely to transmit HIV. And then persons who are not virally suppressed per 100,000 residents. So it's like an enhanced prevalence rate, essentially of a prevalence rate of transmissible HIV. So without going super into all the methods, essentially each measure is done for each county. They're ranked, broken into quintiles to sort of even the playing fields for population centers versus rural areas. And then those quintiles are summed for a score. So we don't have time to dig into the details of each of these right now, but the details of each measure's purpose and a county map for each will be included in the slide deck. And I highly recommend you check out your area and let me know if you want to discuss anything. We keep emphasizing that opt-out screening is not a one-size-fits-all, and understanding these measures in your area may help guide your strategy for increased testing. So this is the resulting composite quintile score from across the 5 measures, with 5 being the lowest possible score in blue and 25 the highest in red. So I want to emphasize this is not showing a proportion of undiagnosed. It does not mean that counties in red have 5 times the undiagnosed HIV as counties in blue. What it means is that counties on the red side of the scale were frequently in higher quintiles for those 5 measures, and the darker red counties were found in the 4th or 5th quintile on all 5 measures. They had the poorest outcomes on all 5 measures. We kind of flatten this out and combine it with the other one because, like I said, each individual measure is useful and tells us something. All of the counties in pink either met that 0.1% positivity rate cutoff or fell into the 4th or 5th quintile on at least one of those 5 measures. So then if that isn't sufficient, we can look at the vulnerability index developed by our HCV colleagues. And so here counties are ranked from least to most vulnerable for an intravenous drug use related outbreak, such as HIV or HCV. And this map returns us to one of our original questions. What is the purpose of opt-out screening? If it's early identification and interruption of outbreaks, such as the 2015 outbreak witnessed in Scott County, Indiana, this map may be the most relevant. On this map, I've outlined Alpena, Clare, Gladwin, Ogama, and Roscommon counties. They're all more vulnerable. They're all in the 4th quintile. They were 5 of only 8 not to be highlighted previously. So if early identification and interruption of outbreaks is the main goal, this map would be most relevant again. So these counties have these outlying counties have very, very few new diagnoses. But if HIV were to be introduced into the intravenous drug using population, it could rapidly transmit if not caught early. And EDs are a prime location to identify and interrupt such transmissions. So just to review the HIV section, opt-out testing and EDs have the potential to interrupt up to 1 in 3 transmissions. And then the justification by county, again, please check out the slide deck, and I am happy to talk to anybody at any time. My contact information is at the beginning about your area specifically. So for the next few minutes, we'll just talk about some syphilis trends as a big
Jen?
picture. Oh, yes.
Sorry to interrupt. I just wanted to bring a question up from the chat.
Sure.
Going back to some slides before, which is you had brought up Detroit Health Department, and the question was Detroit versus Wayne County in some of your statistics, I think that you were sharing. Like, how is Wayne County differentiated, or in some of the slides that you show?
Like what counts as Detroit local health department jurisdiction versus Wayne County? Or
Yeah, I think this slide in particular.
So Detroit, so it's not actually like the health department we're just talking about anyone. The Detroit local health department jurisdiction is anyone living in the cities of Detroit, Grand Rapids, Detroit, any of the Grosse Points, Hamtramck, Highland Park, or Harper Woods. And then Wayne County is everybody else in Wayne County outside of those cities. Does that help?
I think so.
Does that
Sharon,
answer the question?
certainly let us know if that answers your
No,
question.
that does not help, because Detroit is the only one, or Wayne County is the only one that's broke up into 2 separate health departments. Detroit has one total itself. Then Wayne County has one. When you said the number of 160, were you talking about Detroit only, or were you talking about Detroit and Wayne County? Was it both?
That was just Detroit. Yeah, just Detroit.
And so what about the numbers in Wayne County?
I think it's the same shade as Oakland. It's around 30 also. I just didn't put numbers on every single one because, like I said, you wouldn't be able to see anything. So this one was really just meant to emphasize that there are counties of interest outside of the major urban centers that we usually focus on. So Wayne County would be right around 30 also.
Okay, Jen, I hope that answered your question, Sharon. There's also one more question in the chat before moving on to the
Yes.
syphilis, which is, you may have to read this. I'll read it out loud though, but is there a link between elevated vaccine resistance in a population and higher unknown HIV positive population? And Lizzie, if you can come off mute and just clarify a little bit that question, I think that could help us.
I didn't know if a corresponding link or any indication had been noted where there's higher levels of vaccine, just in general, vaccine resistance also seem to correlate with a higher unknown population of HIV positive patients.
We have not looked at anything like that. The only vaccine and HIV connection that we did was analysis that we've done was specifically for the COVID vaccine, and just demonstrating that individuals who received Ryan White were much more likely to get vaccinated for COVID.
Okay.
Okay.
Jen, there's one more question that just popped
Oh,
in.
okay.
There's a comment about Mackinac Island. Yeah, I appreciate you calling that out. But then there's this other question about demographic look at incidence and prevalence. If you've looked at key populations, there's a few vulnerable ones called out in various counties.
I cannot see the chat while I'm sharing my screen. I'm hang on, I might be able to, let's see. Oh, there we go. Now I can. Oh, what I want. Yes. Sorry. Yes, we do. I mean, we do look at key populations, and honestly, like I would love to talk to you guys about HIV data for 3 hours. So it really, anything that left off was not really intentional. I was just trying to get to the pieces that I thought would most interest ED docs that also has not been disseminated a lot elsewhere.
Yeah,
yes,
sounds perfect.
Mackinac County. I'm talking about the county, not the island.
Okay, I think you're good to go to the next sections, Jen.
Okay. And yes, but about that, like, if you want anything about your county or your area in particular, it doesn't even have to be these topics. Anything, just talk to me and I will happily give it to you. So syphilis trends and ED diagnoses. First, big picture for STIs, highest diagnosis rate is chlamydia, followed by gonorrhea, and then syphilis and HIV are down here along the bottom. And if we break that out, you can see that latent syphilis has really been increasing over the last 10 years. And primary and secondary syphilis has also significantly increased, but did go down in 2023. So for all STIs, including HIV, we're still trying to get a handle on post-2020 norms. Pre-2020, an increase or decrease in diagnoses was a solid proxy for new infections, but that is less certain now. Gonorrhea decreases, and these gonorrhea decreases and this decrease in in primary and secondary syphilis at least seems to be a true decrease based on treatment efforts. But we are still getting a handle on that. I threw this on here just to show the rationale behind the recommendation that if you test for syphilis, test for HIV and vice versa. The prevalence of HIV among persons diagnosed with syphilis is 500 times the general population, and the diagnosis rate of syphilis among persons with HIV is 400 times the general population. So that's why that recommendation exists. And then the proportion of syphilis diagnoses at EDs or urgent cares has been significantly increasing. It's more than doubled since 2017, similar to HIV. Also similar to HIV, heterosexual men and women are much more likely to be diagnosed at an ED or urgent care compared to men who have sex with men. And as we briefly touched on in the kickoff, EDs really do a great job at diagnosing populations with perceived lower risk, either self-perceived or provider perceived. Unlike HIV, syphilis has significantly increased among heterosexual men and women. They used to account for only 1 in 5 new diagnoses about 10 years ago, and now they're accounting for almost half of all new diagnoses, which is a huge increase. And this increase among women has led to a significant increase in congenital syphilis that we haven't seen since the early 90s. Among the 55 mothers reported in 2023, where a vertical transmission occurred, 65% had no or inadequate prenatal care. So again, EDs have the opportunity to play a systematic role in interrupting transmissions by identifying women with syphilis and linking them to care or connecting them with the health department in order to be linked. And now I will hand it, if there are no questions on that section, I will hand it over to our HCV colleagues.
Thanks, Jen. Do you mind going to the next slide? Thank you. Hi all, I'm Jeff Brusso. I'm the Viral Hepatitis Epidemiology Unit Manager at the Michigan Department of Health and Human Services. Just want to start off with a quick overview of acute versus chronic hepatitis C, as we will mostly be referring to chronic cases throughout the presentation. So for acute hepatitis C, there can be symptoms associated, but not always. About 25% of acute cases of hepatitis C clear their infection spontaneously. About 75% go on to develop chronic hepatitis C, which is the long-term infection that can lead to liver complications and death. And in 2023, there were 2,729 cases of chronic hepatitis C and 77 cases of acute hepatitis C. Next slide, please. Here. Oh,
Did it go too far? Sorry.
Yep, there you go. Thanks, Jen. Here are some of the most recent testing recommendations for hepatitis C. Universal screening is recommended for all adults. Screening is recommended for every pregnant person during every pregnancy. And routine periodic testing is also recommended for those with ongoing risks, as well as anyone who asks for a test. Next slide. And just a review, the recommended testing sequence is a hepatitis C antibody test with reflex to HCV RNA to confirm active infection. Next slide. This slide is looking at the birth year of all chronic hepatitis C cases reported to MDHHS from 2004 to 2012. And you can see the majority of cases were from the 1945 to 65 birth year or baby boomer cohort. Next slide. When looking at more recent cases reported from 2023, we see more of a bimodal distribution with adults born from 1980 to 1995, making up the bulk of cases, and less cases reported in the 1945 to 65 range. So these cases that we're seeing in more in young adults are primarily driven by injection drug use and the opioid epidemic. Next slide. This slide looks at the rate of chronic hepatitis C in Michigan. The rate of chronic hepatitis C has been decreasing since 2017. This decrease is at least partially due to a change in the surveillance case definition for chronic hepatitis C and the introduction of negative electronic laboratory reporting of hepatitis C results in 2019, which allowed for better identification of spontaneous clearance and treatment. Despite a decrease in the number of cases reported each year, the prevalence of Michiganders living with hepatitis C is close to 70,000, according to one recent estimate. There are thousands of patients living with hepatitis C, that are still in need of treatment in Michigan. And so we need to work with providers and organizations to increase testing and link those with active hepatitis C to treatment. Next slide. This slide is comparing the rate of chronic hepatitis C by county from 2019 to 2023. Again, the overall rate has decreased, but some of the highest rates of hepatitis C are in Detroit, which we include as its own county as well for this purpose. And more resources are needed in Southeast Michigan to treat people living with hepatitis C. Next slide. So in order to make treating hepatitis C easier in Michigan, we've worked on removing some of the barriers that have traditionally been in place when it comes to treating Medicaid beneficiaries for hepatitis C through the We Treat Hep C initiative, which was launched in April of 2021. Medicaid beneficiaries and Healthy Michigan Plan beneficiaries are now able to be treated for hepatitis C at little to no cost because of the agreement to make the direct-acting antiviral Mavyret the preferred hepatitis C treatment for the Michigan Medicaid program. As a result of this agreement, now any provider with prescriptive authority can treat patients instead of only specialists prior to We Treat Hep C. After removing many of the restrictions to treating hepatitis C, the success of We Treat Hep C is now dependent on getting more providers to test and cure hepatitis C. Next slide. So this slide shows hepatitis C treatment claims for Medicaid beneficiaries from unique providers by year, looking at our available Medicaid claims data available to us at the state from our Medicaid data warehouse. As a result of removing those provider restrictions I mentioned through the We Treat Hep C initiative, we have seen an increase in unique providers prescribing hepatitis C treatment to Medicaid beneficiaries starting in 2021 that has increased each subsequent year. But we need to keep increasing the number of providers comfortable treating patients to eliminate hepatitis C. Next slide. And this slide shows the number of claims for Medicaid beneficiaries tested specifically in an ED setting, again, using Medicaid claims data from our data warehouse. We can see that more Medicaid beneficiaries have been tested in an ED setting in recent years. A big part of that increase is due to the project my colleague Vishal will be talking about next.
All righty, thank you so much, Jeff. So my name is Vishal Kingabwala. I am the Hepatitis C Disease Intervention Specialist, or DIS Unit Manager, and here to talk about our unit as well as a project we've been doing with the Henry Ford Hospital Emergency Department, increasing hepatitis C testing and interventions. So our DIS unit was created on October 1st, 2021 as an intervention arm of the hepatitis C total care cascade. We currently have 7 active hepatitis C disease intervention specialists doing remote work, working with cases throughout the entire state of Michigan. Our overall mission is to identify and link residents of Michigan living with hepatitis C to medical care, as well as to support cases to eventually achieve cure of hepatitis C. Our goal is to have cases opt into our case management services. And that's one distinction I think that really sets the hepatitis C DIS program apart, is even though a huge emphasis is on linking the patient to treatment, a larger arm of it is following the case through what we call case management services, effectively decreasing the barriers that the patient may experience while getting treated and eventually getting that cure. So our goal is to have our cases opt into these case management services, following the case through the entire continuum of care until achieving that cure, as we had said. The DIS really have many roles. They wear a lot of hats in their journey with the patient. They are health educators, community resource navigators, harm reduction advocates, navigators for MyBridges for insurance and coverage, as well as case managers. We work with hepatitis C cases throughout the entire state, but because the volume does get high, we have been prioritizing our outreach in order to really make a difference. So our priorities are among Michigan's most vulnerable populations, including mothers and babies, as well as justice-involved populations, and some of our higher burden counties, meaning our counties and jurisdictions with the higher disease prevalences, which would be Wayne County and City of Detroit. Next slide, please. So when looking at the specific project with Henry Ford Hospital ED, kind of to give some background, I know everyone hopefully is familiar with Dr. Jacob Mantuffel. He's our partner at the Henry Ford Hospital with this collaboration. It's a collaboration through the Gilead Focus grants, basically introducing best practice alerts with their EMR system in order to increase hepatitis C testing. So Henry Ford began adding these health alerts to their EMR Epic in 2018. Our collaboration with Henry Ford to assist with this linkage to care and eventual treatment began in July of 2022. We currently have monthly collaborative meetings where we discuss status, talk about any cases, troubleshoot what's going on, and look towards the future, what we can continue doing to improve our processes. We have 2 dedicated DIS that work with the Henry Ford Hospital ED. We really want to just increase the amount of testing as well as our linkages to care. Any positive Hep C cases from the ED are sent 2 to 3 times a month directly to our DIS to be contacted. Once they receive this case information, the DIS will provide linkage to medical providers, linkage to medication coverage, whether that's insurance or otherwise, as well as assist with other needs such as transportation or telehealth in order to ensure proper services. The case management services continue until a test of cure is confirmed. This is what's known as an SVR 12 or sustained virological response 12. Effectively, what that means is 12 weeks or 3 months upon completion of your last dosage of medication, a viral RNA test is ordered and taken. If that lab result is undetected, you are known as having an SVR12 negative, meaning the virus has been cleared from your system. That's our ultimate goal in working with our cases. And so that's, of course, the same metrics for this specific project. Next slide, please. So if we take a look at, this is a look of all the cases the DIs have worked. This was pulled in October of this past year. So from July until October, taking a look at our total cases. All of our cases received are sent directly from the Henry Ford ER. We do have a few fluctuations, whether that's an increase of patients seen, increase of positive tests received. But in general, it tends to be a pretty steady flow where we have a pretty good amount. We have these 2 dedicated DIS that do work on these full time. We receive assistance from other DIS if needed, based on capacity to work some of these cases. But in general, we tend to see a good amount of cases. And on our next slide, we'll talk a little bit more about those metrics. Next slide, please. So if we take a look at what some of those numbers actually look like, if we do a bit of a deeper dive, from July 2022 until October of 2024, we've worked a total of 605 hepatitis C cases from the ED. With our 2 DIS, that's about an average of 22 cases worked per month, so about 11 per DIS. More than 87 of these cases were linked to care, with more than 30 of them confirmed as starting treatment, and that can be any DAA medication, and over 16 of them receiving a negative SVR12, which is that test of cure. When looking at some of the demographics for the patient, we found some interesting information. One of them being majority of these patients were privately insured. However, a good majority of them also did receive any sort of recommended linkage services. We did identify quite a few barriers to treatment, and these, what I found was interesting, were written down directly into the EMR as well as our internal tracking system. And there are some definite trends that tended to pop up quite a bit that we noticed. One of them was misconceptions regarding hepatitis C and misconceptions regarding hepatitis C treatment. Both of those were at the top of the list. And that's where the DIS case management services really come in, where we can speak with the patient about, what does it mean to have hepatitis C? What are things that you're looking for? And what does it mean to go through hepatitis C treatment? A common misconception is, it's still the treatment of the old days where we're talking pegylated interferon alpha and ribavirin, some very, intense medications on the system. So we're able to explain, the oral DAAs are a little bit better tolerated nowadays. Another one that we saw quite a bit was competing medical priorities, meaning other issues take precedence. Hepatitis C treatment, a lot of times, as Jeff had said, these are chronic cases, meaning cases that have been around for more than that 6-month period. The patient's perspective is, I've had this for quite a bit, why this wouldn't be a priority. Let me take care of something higher priority first. These priorities would include things like an HIV co-infection, patients that may need liver transplants, as well as patients that want to set up medical care, whether that's a PCP or established care with the hepatitis C provider. There were some medication contraindications that patients had mentioned or providers had talked about, including certain antipsychotics, amiodarone, which is a cardiovascular drug, proton pump inhibitors, calcium channel blockers, as well as certain anti-epileptics as well. Those were the most commonly cited, but there were others as well. Oftentimes, patients were unaware of their hepatitis C status or unaware of their results. Either, there wasn't any connection, they weren't able to get in touch with the provider or with the lab, or just not informed. And then finally, a lot of patients were mistrustful of results on the phone, sort of stemming from the COVID era as well. Not believing, why are you calling me? What is this information? Is this actually legitimate or not? So these are barriers that sort of help inform our work. By understanding these barriers, we're able to tailor our services better to be able to really work with the patient, come to an understanding, and be able to deliver smooth services and smooth linkages while maintaining rapport and trust with our cases. And next slide, please. And finally, if we take a look at some of our takeaways from this project, as Jeff had mentioned, one of the biggest benefits of the project is ED testing for hepatitis C among Medicaid beneficiaries has increased due in part to this project, really promoting increased testing, and from there actively linking to care, making sure we're not losing patients to follow-up if we're able to prevent that. We're really excited to have continued collaboration and innovation between our unit as well as Henry Ford Hospital ED and Dr. Mantuffel and his team. We're really able to kind of increase the outreach for referrals. Traditionally we'd be referring internally towards Henry Ford, such as Dr. Gordon or the CHAS clinic, but we're also able to work with providers of patient's choice as well, whether in network or out. At the end of the day, as long as we're getting them to a provider, that's really the name of the game. We have some non-traditional clinical settings as well that we can work with, including the use of telehealth and a mobile health setting known as the Mobile Integrated Health Unit. We're hoping to pilot a few patients on there, see if that is something that we're able to, eliminate the barrier of transportation or ability to get to a brick and mortar medical site. There's also what I think is really exciting is the Cepheid Gene Expert, which is a point of care rapid blood test that's able to detect hepatitis C and therefore expedite linkage to care and treatment and eventually cure. That is currently a project that's going on where the Henry Ford ED is actually using these devices currently to test for patients in the ED. As of January 2025, so last month, there are about 41 tests that were performed. So this is going to be going on for a while. So during our collaborators, we're always excited to hear about the progress, how that's going. And then another possibility that's been discussed was potentially prescribing from the ED itself. Still a lot of kinks to work out sort of in that work plan, but I think that definitely could be a possibility and something to potentially explore at the end. And that was the end of my section as well. So happy to take any questions. Thank you.
Thanks, Vishal and Jeff. Certainly have a couple minutes here for questions from the group. I think we addressed the ones in the chat, but certainly if there's still some remaining questions from the chat, maybe come off mute.
Hi, this is Crystal. I have a question about HIV studies. I was just curious looking at the rates for the heterosexual female and the heterosexual male. Has there been any study that focuses on people who have been incarcerated, who identify as being heterosexual? And then post-incarceration find out that they're HIV positive and they have infected their partner, their wife, their girlfriend?
So I'm not aware of any studies specifically, like our main survey called the Medical Monitoring Project surveys HIV positive individuals, and NHBS surveys HIV negative, and we are not allowed to conduct those in any sort like prisons or jails. I think anyone on here with more familiarity on that, please interrupt me. So no, we would, because jails do testing at intake, but not exit. So we don't, it's the incarcerated population is extremely difficult to get any sort of reliable data on. I guess that is the short answer. So we don't really have anything definitive or even very good for that question.
Okay, thank you. I was just curious because I know there is like men who are gay for the stay and come home and things are spread to their partner. But haven't seen like data that shows what that looks like.
Yeah, the only data we have even slightly related is the significant decreases among women in general. So like in Wayne County, Black women are the most tested population by far, and diagnoses keep going down. So that's great news, but obviously that is not specifically answering what you are talking about.
Gotcha.
Thanks, Jen. There is a hand I see up. Is it Claudia?
Yeah,
Yeah, feel free to come off mute. Yeah, go ahead.
yeah. Just curious, for the ED docs that are on the call, and there are several on the call, right? What barriers do you have or do your colleagues have around opt-out testing? I'm specifically interested in syphilis right now. And just curious of what barriers. And if anybody's had success in that space, say with conversations with the administration, how have you overcome those barriers?
So I can answer that for my facility. I'm Kristen Sworer. I work at Hurley Medical Center and I'm an emergency physician. And the most recent conversation we had about screening for syphilis in the emergency department, the barrier was the complexity in interpreting the test. Is this an old positive, a new positive, primary, secondary, tertiary, and how do I ensure that they get a test of cure? So, so I think that the we test, you do the rest. Outreach is just starting to reach our physician group, and we're trying to spread that word, but we're not yet there yet as far as ensuring that if a test is ordered, the correct treatment and follow-up can be provided. Though I know that that is not the case because of the health department program.
Thank you. Anybody else?
I mean, I'll add my own 2 cents to this, you know, as an emergency physician as well. I mean, I think we probably do a generally reasonable job in considering sexually transmitted infections like gonorrhea and chlamydia. I think we sort of have an approach to test for those things, but we don't always think about syphilis in the same category, probably incorrectly. And one of the differences is also, of course, the type of test too, where syphilis is really a blood draw, and that adds sort of additional conversation with the patient around that. These are not impossible barriers. I think it's just some of the barriers that you're trying to ask around, you know, some of the realities of sort of the front lines of care. And I welcome other comments too from the group. Other questions? We have just a couple minutes still. All right. Well, I'm not hearing anything else. So let me just wrap things up. Truly appreciate the time and expertise of the state from Jennifer, Jeff, and Vishal on these topics. I learned a lot for sure. I hope many of you did as well. I think this has been said in the chat a few times, but we'll make sure that this recording is available off our webpage for those that want to access it. Just a reminder to complete the survey. I mentioned this in the beginning. There's a QR code there. And that's just, again, some attitudes and perceptions about screening for HIV, just to help us understand our processes. You can also claim CME credits for this presentation. We use the University of Michigan for our CME. Just note that you have to claim this within 7 days. Not our rules, those are their rules. Just recognize there is that limitation and be sure you get it. And then I just want to call out our next learning series, which is April 9th. And I think this is going to be great. We haven't heard the patient voice yet in our learning series. And we've got 2 individuals living with HIV who are going to share their experiences. And I'm looking forward to learning a lot from that learning series. So please get that on your calendar. I think many of you probably already get calendar invites from us, but we're happy to make sure that you have that on your schedule as well. All right, I'll leave it at that. Thank you so much for your time and attention, and really appreciate you investing in this work. Bye.
Thanks. Bye.